Right, hands up, who drank too much last night? Okay, rhetorical. Alcohol's a big problem, and the reason alcohol misuse, I think, complements but also expands on the unplanned care theme is that it touches lives in many different ways. It's a very broad area and therefore cuts across education, public health, primary care, preventative services, social care. It's very broad, and therefore there are opportunities in something that's so broad and so complex for data to somehow bring together what are currently very fragmented and very complex pathways and services. It's estimated that £21 billion is the cost of alcohol-related harm in the UK annually. £21 billion. 3.5 billion spent in the NHS. So it is a big ticket item. It's quite unattractive as well. It's not really an opportunity for investment, but it's perhaps an opportunity for making savings, both within the health service and more widely in society. We start with alcohol admissions, and we've just talked about unplanned care, and of course there is a dimension with alcohol admissions that it impacts heavily on secondary care services. I've just done a weekend on call. Probably saw about 35-40 patients. I would estimate 40 to 50% of those problems I was seeing were related in some way to alcohol. I'm a gastroenterologist, so we get those sorts of patients. So it is a huge component of our acute take and the acute drain on hospital. This was a few years ago when alcohol admissions peaked and exceeded 1 million per year in England. Now, the North West is really good at this. We are at the top of the table. We are in red. And whatever metric you use, whether it be alcohol-related admissions to hospital in general or some of the downsides, the downstream effects of alcohol, like alcoholic liver disease, we do pretty well in the North West. Liverpool is about 40-50% higher than the national average. Blackpool is currently the highest in the country on many of these metrics. So there's no doubt that this is an area that we ought to engage with in the North West and regard as a health priority. One of the challenges and one of the potential ways in which data can help us is alcohol misuse causes a very, very broad range of problems. We just talk about the health problems. There are over 60 conditions associated with alcohol misuse, ranging from the young lady in the top left corner who just gets a bit drunk and falls down and has to call an ambulance, right through to the poor lady in the far right who's now got end-stage liver disease with imminent risk of death, and a whole range of other conditions, both neurological, gastroenterological, cardiological, are linked with alcohol. But it also has an overlap with mental health, and there's a huge problem with mental health problems which interact with alcohol. So very broad. And this is complex, which means that collecting data on alcohol is difficult. Understanding how patients transit between the different pathways of care is complex. And also in terms of running trials, there's very little good evidence in the alcohol area in terms of what works, particularly in terms of health services structures, because it's so difficult to collect data and interpret it in patients who are transiting across very complex areas. And I haven't yet mentioned the social harms, the impacts on families, violence, crime, etc. There was a survey some years ago about the number of agencies involved in delivering some form of treatment intervention for alcohol, and there are over 100 in the North West, and guess what? They're not very well connected. Patients who misuse alcohol, or people who misuse alcohol, citizens, because they're not always patients, may interact with a wide range of agencies and organisations. I work in the secondary care service, so I see the patients who are admitted. But these patients may have brief contacts with a whole variety of people who have opportunities, potentially, to prevent and to intervene, but may not always take them, and don't necessarily share the data they have to enable the transit of these patients through complex pathways to be streamlined, or for the collaboration between the agencies, particularly health and social care, to work effectively. We had a North West Alcohol Conference on Friday, and I was struck by the number of agencies around, and I gave a brief presentation and was sort of approached afterwards from the non-statutory sector, the voluntary sector. They have a wealth of data they collect on their clients, but it is in no way shared with those working in the healthcare system. So at point of care, there is the potential to tap into all sorts of silos and pockets of data, but they're not currently joined up, and likewise in local government. So the vision for alcohol is to somehow transform cooperation. So we're thinking about bringing together the various agencies and sectors together in alcohol to start a conversation, to start understanding what data is available and how that data might be shared more effectively and more purposefully to improve care. So how might we start? Well, we'd first need to understand what data is out there, and not just health data, but the various sources of data, whether that be alcohol sales, licensing permissions, whether it be alcohol-related crime, so that we understand better the various determinants and factors associated with alcohol. We need to agree what the core data items are. We can't collect everything, but at least if we all collect the same sorts of information and have a hierarchy of priorities and capture the important information, and scale that and roll it out across a region, we may be able to start making some sense and understanding better our alcohol problems and targeting interventions appropriately. There are obviously opportunities to capture data in new ways. When a patient comes into hospital, we do all sorts of assessments on them. We collect an audit score. This is an alcohol misuse score. And it's often written down in some case notes and then scanned into a set of case notes and never used or shared in any meaningful way until they come in again when it's collected. Why don't we have apps or ways of capturing that data that's shared and is cohorted so we understand whether we're applying those simple audit measures regularly to all patients and having serial data so that we understand what's happening. So there are ways. There is also ways to link and analyse the data held in all those silos that could potentially help us think about an overall strategy from public health through to secondary care to tackle the alcohol harms in our community. Shared electronic records is a big issue about information governance here. We've talked about pockets of data being held by lots of different agencies. Where are our permissions to share these? How can we engage with citizens and our patients to understand that sharing of this information and converting that information into intelligence is in the patient's interest? And we need, perhaps in the area of alcohol, where it'll be particularly difficult, because these aren't the most compliant of people, to start exploring some of these issues about getting consent and a shared patient record that can be used across the range of pathways and agencies that these patients encounter. New technologies I've alluded to, and of course big data, and there's an important public policy issue here. We don't really have strong evidence to start persuading government to think about things like minimum unit pricing. You remember minimum unit pricing was suggested as one of the ways you might curtail alcohol-related harms, and it sort of disappeared from the agenda, didn't it? Why did that happen? Well, the alcohol industry is a big industry. It's a very profitable industry, and obviously the lobbying and the sense was that perhaps minimum unit pricing wasn't the way to go. If we can build up information and intelligence to better demonstrate the link between alcohol sales, the way in which alcohol becomes available to our population, perhaps we can start making a more persuasive case. So where to start? Well, this is bottom-up. This is stakeholder consultation. And the stakeholder groups involved in alcohol are very broad. And we've started this process already. We have the Liverpool Alcohol Research Alliance. We've already held meetings with stakeholders, including people from local government, people from the ambulance or fire service, to try to get a feel of what data is out there and what are the data frustrations and needs that might help people deliver their care more effectively. We need frontline staff to define what are the simple, early, low-hanging fruit, the easy wins that would help us coordinate alcohol services more effectively. We're going to do some work on pathway profiling. We're going to follow some patients around in their chaotic lives and try and understand what contacts they have, what data opportunities are there after collection, and what sort of data flows are involved in pathways for these patients with very complex lives. We also need, finally, to think about how we share information. We're not all data nerds. Not everybody understands what an indirectly standardised rate is. But we do have a range of people who need to have some common way of sharing information about alcohol harm and the impact and the trajectory over time of interventions. And so we've had some thoughts about this. And people quite like maps. So one of our particular interests in pilot work will be thinking about how we map data constructively so that everybody in the patch can perhaps get something useful. We've done some mapping around my hospital, and we found that 6% of all admissions were due to alcohol-related problems. So 6% of our acute medical take, 1 in 20 patients overall, this covers medical and surgical specialties, related to alcohol. And frequent flyers, it's a pejorative term, but high-intensity service users, 10 or more admissions, 4% of those. So we can get some data, if we simply look at hospital admission data, we can start to understand on a mapping basis as to what our local problem is, understanding local problems. What if we took that down to lower areas of aggregation? What if we plotted the data into lower super output areas, populations of just 1,500 patients, and we started putting our alcohol admissions on that sort of scale, and then we plotted where the GP surgeries were and where the community alcohol clinics were, where the commonest calls for ambulances for alcohol-related problems were, where alcohol-related crime, etc. You could imagine a sort of live map being built up where all agencies and services might have some useful information to be able to target and understand what's happening in their patch. And of course this idea of hotspots. Where is our biggest burden for alcohol? And if we're going to pilot and use community-based, holistic interventions to impact on this problem, where should we start? Well, perhaps in areas of hotspots. And so we've been looking at crime, and we've got some pilot data to look at that, and that's the off-licence story, which is slightly scary. It's a chicken and egg, isn't it? But the density of off-licences and the density of alcohol-related admissions, quite striking. So the plan is very similar to what Tony's already alluded to. Bottom up, not top down. So to start with stakeholder consultation and to understand the problems and find the easy and potentially most profitable ways of moving forward with what may be quite simple data approaches in the first instance. Understand the pathways in alcohol, they're complex. Where is the data, the agencies and people involved? We'll agree some of the key measures and have that hierarchy, what are the key things we need to measure. And then look across the patch, because there's a huge amount happening with alcohol. Blackpool's a hot spot for alcohol, and there's a lot happening across the North West Coast to try and tackle alcohol. This is not reinventing the wheel, but it's trying to see how data innovations can support and improve on existing interventions. We'll create data, we'll share it widely, we'll get iterative feedback into how it looks, and we'll hopefully produce tools and informatics solutions which will help drive innovation in this very challenging and quite Northwest dominant problem. Thank you.